আগে পড়ানো হয়েছে ডেফিনিশন, প্যাথোফিজিওলজিক বেসিস, ক্লিনিক্যাল ম্যানিফেস্টেশনস, ইনভেস্টিগেশনস, ডায়াগনোসিস। আজকের টপিক হচ্ছে ম্যানেজমেন্ট অফ ইসকেমিক ডিজিজ। যেহেতু on the basis of degree of occlusion, especially arteriosclerotic thrombotic occlusion, the clinical manifestations varied in the form of stable angina pectoris, unstable angina pectoris, non-ST segment elevation myocardial infarction, and ST segment elevation myocardial infarction. So management should be slightly different in each and every corner of the ischemic disease. Now coming to the point of chronic stable angina. Now, what is the basic difference between chronic stable angina and unstable angina? Chronic stable angina is predictable. That means it can be predicted on the basis of degree of exertion as well as intensity and frequency. But unstable angina is unpredictable. Definition already গত সপ্তাহে ডিসকাশন করা হয়েছে। Now management of chronic stable angina pectoris. Treatment should be in a ladder fashion. That means from the lifestyle modification to modification or optimization of therapy for the risk factors, then institution of the pharmacotherapy, and last but not the least, that is the invasive strategy including revascularization. That may again divide it into two components: pharmacologic revascularization by means of fibrinolysis or thrombolysis, and the mechanical revascularization in the form of PCI, percutaneous coronary intervention, or percutaneous stent implantation. Stable angina pectoris, the components are explanation of the problem and reassurance. That means explanation of the clinical situation, adverse events that may occur in future, and the rehabilitation process in the society with the normal or near normal level of activity. Then comes the identification and treatment of the aggravating factors. That means that may aggravate the process of ischemic symptoms, especially in the form of angina pectoris or the complications of the ischemic disease, either electrical complications or the mechanical complications. And identification and treatment of the aggravating factors can be subdivided into two parts. One for the conditions associated with the increased myocardial demand and the conditions associated with the decreased oxygen carrying capacity of the blood, as well as reduction in the degree of blood flow to the myocardial segment. Now coming to the point of increased myocardial demand, that may occur in a setting of left ventricular hypertrophy irrespective of its etiology, aortic stenosis, hypertrophic cardiomyopathy, or hyperthyroidism, as well as hypertension. On the other hand, reduction in the myocardial blood flow due to impaired oxygen carrying capacity of blood, as for example presence of the carboxyhemoglobin or severe degree of anemia. We should focus on the management of these two situations. Then coming the recommendations for adaptation of activity as needed. Adaptation of physical activity means institution of a programmed isotonic exercise within the limits of the individual's threshold. That threshold means at that particular point at which development of ischemic symptoms may occur. So, adaptation of activity as needed means institution of a programmed isotonic exercise within the limits of the individual's threshold that may produce ischemic symptoms keeping in mind the exercise does not produce an increase in the heart rate beyond 80 beats per minute. So exercise should be targeted but with the aim of maintaining heart rate at or below 80 beats per minute. Third, treatment of the risk factors. That means history of familial that is the history of cardiovascular diseases and certain cardiac death in the family that should be incorporated in an attempt to the intensified and the integrated approach for management. Second, the other risk factors such as hypertension, dyslipidemia, and diabetes mellitus, as well as chronic kidney disease, should be addressed and treated accordingly, keeping in mind that the lipid management should be with a target of LDL cholesterol at or below 70 milligram percent. So management of the hypertension, diabetes mellitus, chronic kidney disease, hyperthyroidism, obesity, etc. should also be incorporated in the management of the ischemic heart disease. Third, drug therapy for angina. ড্রাগ থেরাপিকে কয়েকটি ক্যাটাগরিতে ভাগ করা যেতে পারে। অ্যান্টি-অ্যাঞ্জাইনাল থেরাপি, that means therapy related to the ischemic process, therapy related to the metabolic process, and lastly, therapy related to the enhancement of the coronary arterial blood flow. And last but not the least, consideration of the revascularization. That means coronary angiography with or without percutaneous coronary arterial intervention. Drug therapy nitrates. It should be given as an ointment, transdermal patch, sublingual tablets, or nitroglycerin spray, as well as intravenous nitroglycerin in intractable situations. And nitroglycerin পর আসছে isosorbide dinitrate, that is sustained release preparation or oral preparation, as well as isosorbide monotitrate, that also be again divided into two: oral short acting and the long acting or sustained preparation. Now, mode of action of nitrates. Number one, enhancement of the epicardial coronary blood flow by means of coronary epicardial vasodilatation. Second, systemic venodilation, that means pooling of blood in the lower extremities, that may reduce the end-diastolic volume and pressure and ultimately wall tension, that may decrease the myocardial oxygen demand. Determinants of myocardial oxygen demand MBO2 সেক্ষেত্রে আগের দিনই বলা হয়েছিল heart rate, contractility, and LV wall stress or strain. Third point, improvement of blood flow into the collateral circulations. And fourth one, slight degree of antithrombotic activity. So mode of action of nitrates: epicardial coronary vasodilatation. Second is systemic venodilation with pooling of blood in the peripheries or in the lower limbs, reducing LV filling pressure and volume with resultant reduction in myocardial wall stress and myocardial oxygen demand. Third, improvement of blood flow in the collateral vessels. And fourth, slight degree of antithrombotic activity. Second, beta blockers. Beta blockers may be used as an anti-anginal agent. The additional benefit compared to the others are prevention of reinfarction and second, prevention of infarction or progression of infarction. একটু ঘুরিয়ে বলা ভালো ফার্স্ট পয়েন্ট প্রিভেনশন or progression to infarction, second reinfarction if already there is an episode of previous infection and infarction. Second, it reduces the cardiac arrhythmias and sudden death. কিন্তু mode of action in the setting of angina pectoris or chronic stable angina is reduction in heart rate, number one. Negative inotropic effect, number two. That means enhancement of the myocardial relaxation that reduces the myocardial oxygen demand. So, reduction in heart rate, number one. Number two, reduction in the myocardial contractility and stroke volume. But the side effect may be severe bradycardia or hypotension. So, in absence of contraindication, beta blocker is an important adjunct in the management of stable angina pectoris, especially cardioselective or partially cardioselective, that means beta 1 receptor blocker such as bisoprolol, metoprolol, carvedilol, labetalol should be used in the setting of angina pectoris. The contraindications are severe degree of bradycardia, presence of AV block or peer interval more than or equal to 0.24 second, presence of reactive airways disease like bronchial asthma, like chronic obstructive pulmonary disease, or severe degree of hypotension. So, factors to be considered before institution of beta blockade therapy should be absence of heart failure. Number two, absence of hypotension, that means BP should be above 100 millimeter of, systolic BP should be above 100 millimeter of mercury. PR interval should be less than or equal to 0.24 second or absence of the advanced AV block or AV conduction disturbances. Third, the calcium channel blockers. Routinely, calcium channel blockers are not indicated in the management of angina pectoris, especially chronic stable angina pectoris. ক্যালসিয়াম চ্যানেল ব্লকার্সকে আমরা দুটো ভাগে ভাগ করতে পারি, dihydropyridine calcium channel blockers, non-dihydropyridine calcium channel blockers. The first one include amlodipine, nifedipine, and the second one include verapamil and diltiazem. So calcium channel blocker should be indicated in a setting of contraindication to beta blocker therapy, poor response or efficacy, or কি বলবো presence of advanced degree of AV block. But calcium channel blocker should be used in this situation alone or in combination with the beta blocker. Now the choice is the dihydropyridine calcium channel blockers, either nifedipine, that means long acting nifedipine, or amlodipine, not diltiazem or verapamil, because of their negative inotropic effect that may precipitate heart failure. Now, why not the short acting calcium channel blocker? Short acting calcium channel blocker may produce an acute exacerbation of the myocardial ischemia and progression to the myocardial infarction. So long acting calcium channel blocker, that means long acting nifedipine or amlodipine should be instituted alone or in conjunction with the beta blockade therapy. In case of একটা কথা বলতে ভুলে গেছি বিটা ব্লকের থেরাপির সম্পর্কে। উইথড্রল অফ বিটা ব্লকার ইন এ সেটিং অফ ischemic heart disease should be withdrawn in a gradual titration process. That means over a period of 2 weeks, sudden withdrawal of beta blocker may precipitate acute myocardial infarction or even worsening of the ischemia. So withdrawal of beta blocker should be done with a gradual titration process over a period of 2 weeks. আর একটা কথা বলতে ভুলে গেছি, নাইট্রেট থেরাপি শুড বি গিভেন with a definitely at least 8 hour nitrate free period, or কোনো বইতে বলা আছে 10 to 12 hours of nitrate free periods because of the development of tachyphylaxis. এটা তোমরা ফার্মাকোলজিতে পড়েছো। সুতরাং at least or minimum 8 hour or preferably 10 to 12 hour nitrate free interval is recommended in the management of angina pectoris. তারপর আসছি antiplatelet drugs. That means target is at least LDL cholesterol below the level of 70 milligram percent. In case of combined dyslipidemia, that means elevation of the LDL cholesterol as well as elevation of the serum triglyceride. The focus should be first on the LDL cholesterol, then on the non-HDL cholesterol, not the triglyceride, unless or until it exceeds the level of 500 milligram percent. আস্তে ফোনিক কথাবার্তাটা আস্তে। আচ্ছা আস্তে বলিনি, কথা আস্তে বলতে বলেছি, ঠিক আছে। যে কথাটা বলছিলাম সেটা গুলিয়ে গেল। লিপিড, সো ফার্স্ট হচ্ছে dyslipidemia in the form of isolated dyslipidemia like elevation of the cholesterol and LDL cholesterol. Target is 70 milligram percent LDL cholesterol. In case of combined dyslipidemia, now assess the value of the triglyceride. If it exceeds the level of 500 milligram percent or 500 milligram percent, we should institute fibrate like gemfibrozil. Otherwise, when the triglyceride concentration is above 150 but less than 500, then the target is to reduce the non-HDL cholesterol to less than 130 milligram percent. That means total cholesterol minus HDL cholesterol. This should be the target. Then the anti-platelet drugs. আচ্ছা একটু গুলিয়ে গেছে, অ্যান্টিপ্লেটলেট ড্রাগ সম্পর্কে বলছি। দ্য ক্লাসিক্যাল অ্যান্টিপ্লেটলেট ড্রাগস আর টাইম অনার ড্রাগস ইজ অ্যাসপিরিন, দ্যাট ইজ ইকোস্প্রিন or equivalent in the dose of 160 to 325 milligram per day, with or without clopidogrel, that is the loading dose is 300 to 600 milligram per day and maintenance dose is 75 milligram per day. But combination therapy is usually not indicated in chronic stable angina pectoris, either aspirin or in case of aspirin allergy or aspirin intolerance, we should institute clopidogrel. Dual therapy usually not indicated in a setting of chronic stable angina. এবার ঘটনা হচ্ছে দুটো কথা বলতে আমি মিস করে গেছি, যে ক্রনিক স্টেবল অ্যাঞ্জাইনা বলতে গিয়ে বলেছি ক্যালসিয়াম চ্যানেল ব্লকার শুড নট বি রুটিনলি ইউজড ইন দ্য ক্রনিক স্টেবল অ্যাঞ্জাইনা, বাট ইন কেস অফ ফ্রিঞ্জ মেটালস অ্যাঞ্জাইনা, in case of fringe metals angina, The therapy of choice is nitrate plus calcium channel blocker, especially long-acting calcium channel blocker, or more precisely dihydropyridine calcium channel blockers. আর অ্যাসপ্রিন সম্পর্কে একটা কথা বলে রাখা ভালো, aspirin is almost always indicated in all the situations of ischemic heart disease except one. At the initiation of therapy of fringe metals or variant angina, aspirin may exacerbate or increase the ischemic symptoms, so be cautious regarding aspirin in a setting of or suspicion of fringe metals angina. নাইট্রেট সম্পর্কে আরও একটা কথা বাদ চলে গেছে, দ্যাট ইজ দ্য নাইট্রেট শুড বি অ্যাভয়েডেড ইন দ্য আরভি ইনফাক্ট that is suspected on the basis of inferior wall infarct or posterior inferior infarct with elevation of the jugular venous pressure or jugular venous distension, hypotension, but clear lung fills. Jugular venous distension, hypotension, clear lung fills. Classical triad of right ventricular infarction especially occurs in a setting of inferior or posterior inferior wall infarct. RV infarct is diagnosed on the basis of right-sided precordial leads, cardiac biopsy, and the definitely regional wall motion abnormality on imaging, that is the echocardiography. Management is somewhat different. Nitrate is contraindicated. Almost all the anti-anginal drugs are not effective. এক্ষেত্রে ভলিউম এক্সপানশন অ্যান্ড fluid resuscitation is the therapy of choice. Now other therapy, ACE inhibitors. Classically chronic stable angina pectoris এর ক্ষেত্রে আমরা ACE inhibitor প্রেসক্রাইব করি না, কিন্তু stable angina pectoris in a setting of hypertension or diabetes mellitus, ACE inhibitor is indicated, or ACEI is indicated in the ST segment or non-ST segment elevation myocardial infarctionের ক্ষেত্রে long term therapy হিসাবে. Otherwise, ACE inhibitor is not a classical drug for the management of chronic stable angina, except in situation of diabetes mellitus or hypertension. Second, ranolazine, that means a drug acting on the potassium channel opener that may result in load of the sodium as well as calcium in the cardiac myocytes, especially cardiomyocytes, reducing the myocardial oxygen demand. Virtually, it is the metabolic therapy or metabolic drug therapy. আগেরগুলো যেগুলো বলা হয়েছিল অ্যান্টি অ্যাঞ্জাইনাল থেরাপি, এক্ষেত্রে আমি আসছি যে মেটাবলিক থেরাপি ফর দ্য অ্যাঞ্জাইনা পেক্টোরিস. Then comes the SGLT2 inhibitors. Again, this is not classically indicated in chronic stable angina pectoris, but SGLT2 inhibitor has classical advantage of cardiorenoprotection. It decreases the glomerular hypertension and glomerular hyperfiltration, as well as it has got some beneficial impact on the myocardium by means of regulation or reduction of the volume status, that means reduction of the myocardial oxygen demand. The only indication is angina pectoris with an unfortunate LV ejection fraction less than equal to 40%. SGLT2 may be indicated. Third, the নিকোরান্ডিল, এটা না বললে কার্ডিওলজিস্টরা আমাকে ক্ষমা করবে না, তারা লিখেই থাকে. নিকোরান্ডিল is an angina anti-anginal drugs. It can be given in refractory cases. Virtually, its main role is the prevention of anginal attacks in a setting of recurrent angina pectoris. That's all regarding the drug therapy. Now, unstable, chronic stable angina pectoris, the situation of the coronary revascularization and invasive strategy that is indicated in certain definite situation like unstable phases of the disease, that means unstable angina যদি develop করে progression to unstable angina. Second, intractable symptoms despite optimum medical therapy. Third, high risk coronary anatomy like left main or proximal left anterior descending coronary artery involvement. Lastly, the diabetes mellitus and definitely आगे बोललाम lastly and definitely impaired LV systolic function. So indications for revascularization: one, progression to unstable process; second, intractable symptoms; third, high risk coronary arterial anatomy like left main or left proximal anterior descending coronary artery; fourth, diabetes mellitus; and fifth, impaired LV function. Now, non-ST segment elevation and MI and unstable angina management is more or less similar. সেক্ষেত্রে first of all, that should be included in the rule in, rule out or observation strategy. Unstable angina or non-ST segment elevation, myocardial infarction, দুটোকে আমরা একসঙ্গে ডিসকাস করি from the viewpoint of management. And at that particular point, we should follow the rule in, rule out or observation pathway. What is rule in, rule out or observation pathway? আগের দিন ডিসকাসড হয়েছে। Clinical suspicion of rule in for non-ST segment elevation ACS by clinical features, cardiac troponin or STTF changes on the ECG. এরকম কন্ডিশন থাকলেই ফার্স্ট পয়েন্ট হচ্ছে হসপিটালাইজেশন অফ দ্য পেশেন্ট, স্পেশালি ইন আ ইন্টেন্সিভ করোনারি কেয়ার ইউনিট উইথ কন্টিনিউয়াস ECG monitoring facilities. This is the rule in and rule out process. First of all, clinical suspicion of non-ST segment elevation without immediate indication for coronary angiography. High index of clinical suspicion of acute coronary syndrome, especially non-ST segment elevation MI or unstable angina. The first step is the estimation of cardiac troponin level at 0 hour, at 1 hour, at 2 hour. তিনটে রেজাল্ট আসতে পারে। ফার্স্ট রেজাল্ট, this is the very low level of the cardiac troponin or low initial increment in the level of troponin at 1 hour or at 2 hour. Then the rule out pathology, অর্থাৎ এক্ষেত্রে আমার অ্যাগ্রেসিভ ম্যানেজমেন্টের প্রয়োজন কিছু নেই, ওপিডি বেসিসে চিকিৎসা করার জন্য ডিসচার্জ করে দাও। সেকেন্ড, initial high cardiac troponin level or an increment in the cardiac troponin level substantially at 1 hour or 2 hour. This is the rule in pathology that should be hospitalized with the preparation of aggressive management. And in between these two, nothing should be done, observation only in the inpatient department. Now, drug therapy more or less is same, already discussed in the chapter of chronic stable angina pectoris, like nitrates, like calcium channel nitrates, like beta blockers, calcium channel blockers, ranolazine, ACEI, antiplatelet therapy, like aspirin, anti-lipid therapy, aggressive management of the diabetes mellitus, hypertension, or hyperthyroidism. And the invasive strategy, প্রথম কথা হচ্ছে নন এসটি সেগমেন্ট এলিভেশন এবং আনস্টেবল অ্যাঞ্জাইনা পেক্টোরিস ইনফার্ক্ট হওয়া সত্ত্বেও কিন্তু ফিব্রিনোলাইসিস বা থ্রম্বোলাইসিসের কোনো রোল নেই। এক্ষেত্রে করোনারি অ্যাঞ্জিওগ্রাফি থেকে সরাসরি আমরা যেতে পারি অবজারভেশন, পিসিআই অর সিএবিজি। কখন আমরা ইমিডিয়েট অ্যাঞ্জিওগ্রাফি করব, সেটা হচ্ছে হাই রিস্ক ফ্যাক্টরস ফর দ্য development of adverse cardiac event and certain situations of the high risk factors and the normal or low risk factors. So immediate angiography or early angiography. Early angiography means angiography with a period less than 24 hours. Immediate angiography means angiography at presentation within 120 minutes of the acute onset of symptoms. Very, very high risk immediate angiography. What are the very, very high risk or very high risk features? One, hemodynamic instability or cardiogenic shock. Second, recurrent or ongoing chest pain, refractory to medical management. Third, heart failure presumed secondary to the ongoing myocardial ischemia. Fourth, life-threatening arrhythmias or cardiac arrest after presentation. 5. Mechanical complications. 6. Recurrent dynamic ECG changes of suggestive of ischemia, particularly with intermittent ST segment elevation. These are the very high risk factors that constitute the indication for immediate coronary angiography and subsequent action in the form of either PCI or CABG. Or the high risk factor, a confirmed diagnosis of STEMI or current recommended ACS criteria, confirmation of the diagnosis of non-ST segment elevation myocardial infarction, dynamic ST segment or TOF change. Third, transient ST segment elevation. Fourth, a grace risk score more than 140. এটা হচ্ছে more clarified from what I have said. Very high risk hemodynamic instability, cardiogenic shock, recurrent refractory chest pain, life-threatening arrhythmias, mechanical complications. High risk confirmed STEMI, grace score more than 140, transient ST segment elevation, dynamic ST segment and TF changes suggestive of ischemia. Course of action, very high risk immediate strategy, that means immediate angiography or invasive strategy. High risk early invasive strategy, that is the within 24 hours, and non-high risk selective or inpatient invasive strategy. এটাকে একটু ইলাবোরেট করা দরকার আছে। Selective or inpatient. Selective means that depends on the suspicion of the complexity of the coronary arterial anatomy. And inpatient means already for some other reasons invasive strategy is indicated in a patient admitted in normal ward. So selective or inpatient strategy, that is the selective or inpatient invasive strategy. So depending on the presence of the ECG, number one, clinical symptoms, number two, and the presence or absence of the very high risk factor, non-risk factor, strategy should be immediate invasive, early invasive, and lastly selective or inpatient invasive strategy. Clear? Now, the most common is ST segment elevation myocardial infarction. First, immediate pharmacotherapy, then pharmacoinvasive therapy or invasive therapy. ফার্মাকো-ইনভেসিভ থেরাপির কথা বলা হচ্ছে এ কারণে যে সব জায়গাতেই পিসিআই বা সিএবিজি ফেসিলিটিস থাকে না। সুতরাং পিসিআই or CAB facilities is very much crucial in the management of ST segment elevation MI. কিন্তু আনফর্চুনেটলি মেজরিটি অফ দ্য সেন্টারে ইমিডিয়েট পাওয়া যায় না, কারণ ডোর টু ডিভাইস ডিউরেশন ইজ 120 minutes. That means immediate angiography with PCI or CABG done within 120 minutes of presentation. Otherwise, we should go for fibrinolysis and followed by either immediate or early invasive strategy depending on the location of the center and then the PCI or CABG. But initial pharmacotherapy, first of all, buccal aspirin, 160 to 325 milligram aspirin should be chewed immediately, followed by a maintenance dose of 75 to 160 milligram per day. Why buccal chewing? Because in a setting of myocardial infarct, there may be nausea, vomiting, and delayed gastric emptying, or may produce gastric erosion. So, buccal absorption is essential in order to avoid these peptic disorders, that means disorders of the dyspepsia. And mucosal absorption is high, so initial pharmacotherapy is aspirin, immediate 160 to 325 milligram aspirin, followed by 75 to 325 milligram per day, plus minus clopidogrel. Loading dose is 300 to 600 milligram per day, followed by 75 milligram per day. এক্ষেত্রে কম্বিনেশন থেরাপি ম্যাক্সিমাম ডিউরেশন ইজ 1 year, preferably at least 14 days, but maximum duration is at least 1 year. Then clopidogrel should be discontinued. Second, the oxygen therapy. তার আগে বলা থাকা রেস্ট, usually bed rest is given for 6 to 12 hours, but in a stable clinical condition or scenario, the patient may sit in the bed with dangling his or her feet. In a wheelchair within the 24 hours, and the discharge at about 3 to 5 days. This is the rest. Then the diet, low calorie intake and nothing by mouth for at least 4 to 12 hours, except with sips of water because of the reduction of nausea, vomiting, etc. And third, the oxygen. Normally, AMI oxygen is not indicated unless there is evidence of hypoxemia as evidenced by arterial oxygen saturation less than 90%. Then oxygen can be given 2 to 4 liters per minute at least 6 to 12 hours. Now, pain relief. First, morphine. Morphine reduces mental distress by relieving anxiety. Second, it reduces hemodynamic responses or distress by means of systemic, arteriolar, as well as venous dilatation, reducing myocardial oxygen demand. And in certain situations, এটা কিন্তু খুব crucially বলার চেষ্টা করবে, in certain situations, it may reduce the hemodynamic distress by means of reduction of pulmonary congestion. But caveat is there may be respiratory depression that is hazardous. So, third beneficial impact. Morphine dose usually 2 to 4 milligram IV at an interval of 5 minutes till abolition of pain, especially chest pain. Then the nitrates. First, sublingual nitrates. আচ্ছা ক্যাভিয়েট কি, মরফিনের একটা ভেগোটনিক অ্যাক্টিভিটি আছে দ্যাট মে প্রডিউস হাইপোটেনশন, দ্যাট মে প্রডিউস ব্র্যাডিকার্ডিয়া. সো মরফিন ইজ নট ইন্ডিকেটেড ইন inferior wall infarct or posterior inferior wall infarct or right ventricular infarct. কারণ inferior wall infarct or posterior inferior infarct, initially there is vagotonic activity with the presence of bradycardia and hypotension. So morphine should be avoided in a setting of inferior wall infarction. Second হচ্ছে nitrate. 0.4 milligram at an interval of 5 minutes nitrate আমরা apply করতে পারি till abolition of the chest pain, keeping in mind the heart rate, the BP, and the presence and the development of the intractable headache or other toxicities. In case of no response, we should go for intravenous nitroglycerin. Then comes the beta blocker, that means IV beta blocker. Again, the benefit is pain relief, number one. Number two, cardiac relief in the form of reduction in the heart rate, cardiac contractility, and etc. And beta blocker has got added advantage of prevention of reinfarction and sudden cardiac death by preventing ventricular tachyarrhythmias. The initial dose is 5 milligram IV at an interval of 2 to 4 minutes. Maximum dose is 15 milligram, followed by oral dose, initially 50 milligram 6 hourly for 48 hours, then 100 twice a day. সেটা চলল. Then antithrombotic therapy, more or less same, aspirin plus minus clopidogrel. Antiplatelet therapy is aggressive, either less than or equal to 70 milligram percent or at least 50% from the basal value. So aggressive lipid management is much more crucial in this setting, particularly ST segment elevation MI. Analysis. যেখানে PCI facilities থাকছে না, অথচ আমার হাতে 120 মিনিট 120 মিনিটস নেই যে পেশেন্টকে আমি PCI সেন্টারে পাঠাতে পারছি, সেখানে আমরা থ্রম্বোলাইসিস করতে পারি। থ্রম্বোলাইটিক এজেন্টসকে আমরা দুটো ভাগে ভাগ করতে পারি, একটা হচ্ছে বোলাস থ্রম্বোলাইটিক্স আর একটা হচ্ছে ইনফিউশন থ্রম্বোলাইটিক্স। বোলাস থ্রম্বোলাইটিক্সের মধ্যে পড়ছে টেনেকটিপ্লেজ, দ্যাট ইজ দ্য TNK, আর রেটিপ্লেজ। আর ইনফিউশন থ্রম্বোলাইটিক্সের মধ্যে পড়ছে স্ট্রেপ্টোকাইনেজ, টিসোপ্লাজমিনোজেন অ্যাক্টিভেটেড। এক্ষেত্রে কিন্তু ডোর টু নিডল duration should be less than or equal to 30 minutes. But thrombolysis can be given up to 12 hours. Classical time is, that is the FMC to device, but dot to needle. Dot to needle duration is 30 minutes or less. This is the classical, but may be given up to 12 hours in a setting where no other facilities is available. Now, what is the goal of successful thrombolysis? Number one, relief of chest pain. Number two, resolution of the ST segment elevation by more than at least 50% from the initial elevation. Number three, no development of any arrhythmia or proarrhythmia and absence of the heart failure or hemodynamic instability. These are the criteria for successful thrombolysis. Now revascularization strategy, সেখানে therapeutic goal হচ্ছে TIMI score 3. TIMI score 3 টা কি? Grade 0, that means total occlusion, no penetration of contrast material, no blood flow, no perfusion. Grade 1, slight degree of penetration of the contrast material with no perfusion. Grade 2, delayed flow but with adequate perfusion. And 3, that is the normal flow and normal perfusion. So TIMI grade 3 is the goal of revascularization therapy, that is assessed by the process of angiography, either thrombolytic therapy or the percutaneous coronary intervention therapy. Goal is TIMI grade 3 flow. Now dose, এগুলো বলার আশা করি সময় নষ্ট হবে। Streptokinase dose হচ্ছে 1.5 million units over a period of 1 hour. Tenecteplase, that is TNK, dose is 0.53 milligram per kg over 10 seconds. That is the bolus dose. Tissue plasminogen activator, initial bolus হচ্ছে 50 milligram, then the 15 milligram, then the 50 milligram over the next 30 minutes, then the next 35 milligram over the next 60 minutes. Intraindications to the fibrinolytic therapy. A history of cerebrovascular hemorrhage at any time, or a history of non-hemorrhagic stroke or other cerebrovascular event within the past year. So hemorrhagic stroke at any time, or non-hemorrhagic stroke or or other cerebrovascular event within the past year. Severe degree of hypertension, that means BP level, systolic BP more than 180 millimeter of mercury and or diastolic BP 110 millimeter of mercury. Then suspicion of aortic dissection and active internal bleeding excluding menses, and advanced age, but there should be a judgment regarding the benefit and efficacy of the fibrinolytic therapy. The relative contraindications are: patient is on anticoagulation therapy with an INR exceeding 2.5. A recent, that means less than 2 weeks, of invasive procedure or surgery. Number 3, prolonged, that means a duration of 10 minutes or more, CPR. Then non-bleeding diathesis, pregnancy, hemorrhagic ophthalmic condition like diabetic ophthalmic disorders with hemorrhage or diabetic hemorrhagic retinopathy, active peptic ulcer disease, and a history of severe hypertension that is now controlled. This is the relative contraindications. And allergy to streptokinase. If any history of allergy to streptokinase infusion, streptokinase should not be administered between 5 days to 2 years. Invasive strategy, working diagnosis of STEMI, immediate reperfusion therapy, that is PPCI, or working diagnosis of non-STCACS আগেই বলে দেওয়া হয়েছে। এবার লং টার্ম থেরাপি ফার্স্ট হচ্ছে মডিফিকেশন অফ এটা দেখুন মডিফিকেশন অফ আ লাইফস্টাইল ইনক্লুডিং স্মোকিং সিজেশন, হেলদি ডায়েট অ্যান্ড ওয়েট কন্ট্রোল। Second, long-term antithrombotic therapy or preload therapy. Third, beta blockade therapy that should be continued according to the clinical situations. And the short-term therapy with ACEI and regular monitoring or check-up for progression of the disease, development of the heart failure or other complications including electrical instability or hemodynamic instability like cardiogenic shock. That's all.